Okay. Good afternoon, everyone. I'm Jenna Tucker. Thank you for joining us and being part of the Brain Injury Alliance of New Jersey's annual seminar. Before we get started, I'd like to remind everyone to enter your full name into the chat, please. This is our virtual sign-in sheet. If you're going to request CEUs, remember that you must attend this workshop in its entirety, complete the workshop evaluation, and if required by your discipline, complete a post-test. I will be entering that link in the chat for your convenience. Zoom will provide a report of how long each of you stayed in the workshops. CEUs cannot be given if attendance is not verified. Questions are encouraged. Please enter your questions into the chat and they will be addressed at the end of the presentation. Today's workshop is identifying essential elements of community reintegration programming. Our presenters are Usha Prasad and Kevin Mazzola. Usha Prasad and Kevin Mazzola are doctoral candidates at Fairleigh Dickinson University. Ms. Prasad is a pre-doctoral rehabilitation and neuropsychology intern at NYU Langone Rusk Rehabilitation and will be a postdoctoral neuropsychology fellow at the University of Connecticut in the fall of 2021. Mr. Mazzola is a neuropsychology extern at Columbia University Medical Center and rehabilitation specialists. Their training includes a focus on assessment and treatment across various clinical populations, including persons with ABI in the rehabilitation setting. It is my honor to introduce them to you today, and I turn the presentation over to them.
Thank you, Jenna, for that very, very kind introduction. And thank you, everybody, for coming today. It's great to see so many people here, and we're very excited to be a part of this. So bear with me while I pull up the slides here and adjust things around. Please just let me know, chime in if there's any issues seeing anything here, but hopefully it's good. Okay, so as Jenna introduced, our talk today will be focusing on identifying the essential elements of community reintegration programming. I don't need to reiterate this, so we'll jump right ahead. First, we'd really like to thank the contributors to the paper, the narrative review that this information today is based on. So a very, very big thank you to Dr. Gordon, Dr. Greenwald, Dr. Brickfield, and Alana Beecher for their contributions to this project. This presentation could not have happened without them. So quickly, just some objectives that we'll be focusing on today. So our goals are really to provide an overview of the impact of the multifaceted sequelae of acquired brain injury on both the survivors, so the individuals who have that brain injury, and their families, which includes the caregivers, but also other family members as well, following the transition from acute care. We're gonna be providing an overview of the community reintegration program characteristics, and specifically with a focus on some day treatment program and residential programming for survivors. And specifically as we go through this, we're going to be talking about some methods to engage the caregiver to really facilitate this process across the rehabilitation continuum. And likewise, we will be touching on the needs of the survivors, the caregivers, and also the dynamic of the survivor-caregiver relationship across this continuum. So just some brief background. As I'm sure everybody here knows, the cognitive, emotional, and behavioral difficulties associated with ABI can be long-term and really do profoundly affect the life trajectory of the survivors and their families and the caregivers as well. So while those with more mild injuries may recover relatively quicker, those with moderate to severe injuries can require ongoing, continuous long-term care. And it often falls on the family, which is often a parent, but also can be spouses of the person with the ABI, to assume the caregiver role, often abruptly and without really adequate preparation, given just the nature of ABI. So unfortunately, the transition to post-acute care, from acute to post-acute care, can be poorly coordinated, which may result in a bit of a breakdown of the system. And this could be for any number of factors. Some of the main factors are insufficient resources or a lack of education, inappropriate placements within the community, financial limitations, and just lengthy and burdensome funding application procedures. So given these barriers to care, our narrative review really focused on highlighting the essential elements of programming as part of this comprehensive care for individuals with ABI. So to do this, the research team first searched papers between 1995 and 2020 using the following combinations of keywords: traumatic brain injury, acquired brain injury rehab, comprehensive community reintegration, residential programming, home-based rehab, caregiver burden, and caregiver support. And references were obtained by searching a variety of online databases. So to start out, inclusion criteria in this paper included articles published in English, articles published in academic journals, articles focusing on adult brain injury rehabilitation, articles related to rehabilitation within the context of community integration and residential programming, articles addressing patient and caregiver needs over the long term. And this investigation focused mostly on moderate to severe brain injury, although some articles included a subset of more mild acquired brain injury as defined by the authors. So starting out, there was over 3,000 articles identified. These were pared down to 560 that were screened by title and abstract, of which many were not relevant. So 93 potentially relevant articles were identified, and 12 others were obtained from the reference lists of other articles. 34 of those were non-relevant because they looked at, for example, a non-adult population, a non-brain injury population. They weren't focused on rehab. So eventually, 74 articles were included in this conceptual manuscript. Those articles were reviewed and examined and then categorized based on topic and focus into these categories: community integration, caregiving, case management, experience and the needs of individuals with brain injury, general brain injury rehabilitation, and then post-acute care and rehabilitation, and type of programming. So to start out, following the extraction and review of articles that was just described, we began identifying and describing the essential elements identified within the literature of community reintegration programming. The first of these that I'm going to talk about is the caregiver-survivor relationship, and specifically looking at the transition coming from the acute setting. So often following acute care, individuals with ABI begin their transition to the home setting, which requires caregivers to really reorganize their professional and personal activities and responsibilities. This transition can be very stressful. It can also include a lot of optimism and hope, but the stress can be very palpable here and requires caregivers to adapt to new and unanticipated roles. They need to quickly mobilize resources to adapt to these roles. And they need to adapt even the physical home environment to fit the needs of the survivor, for example, safety considerations, if machines are necessary, assistive devices. So as a result, caregivers may have difficulty participating in society in the ways that they were used to prior to assuming this role. And that could be socially, vocationally, whatever it may be. And with the assumption of these responsibilities, caregivers may find it difficult as well to maintain the supports that they previously had around them. And as a result of that, they may begin to experience their own decline in quality of life. And unfortunately, as caregivers' own quality of life may decline, this can impact just not only their own well-being, but the individual receiving the care. And with inadequate supports around, both the caregiver and the survivor may be experiencing a decline in quality of life. And the Smeets and colleagues here highlighted that caregivers and survivors often report a low life satisfaction, high subjective burden, and depressive symptoms are really common. And one of the things here that I think is important to take away is that caregiver satisfaction is associated with a feeling of mastery and agency and active coping on the part of the survivors. So I hope one of the takeaways here is the really interconnected relationship between the caregiver and the survivor, and how important each aspect is and how bidirectional this relationship can be. Also, I think it's important to consider the younger age of many individuals with ABI, which means that caregivers really may be taking on a challenge that lasts into their elderly years, their own elderly years, and the survivors' elderly years. And one of the most frequently cited concerns here for parents, at least, was a concern about one, just the cause of the brain injury, the diagnosis of it, but also on one of the concerns was the long-term planning considerations for accommodation of their loved ones. So as I sort of touched on before, as caregivers age themselves, they're going to have to manage their own health-related concerns, which can add to the caregiver burden. Given that caregivers have to reorganize a lot of their activities, they may have lost out on some work and financial opportunities, while at the same time undergoing increased financial and time strain. And, often while these are family members, I think it's also important to remember that these may be partners and spouses as well. So depending on the financial structure of these relationships, it could be really burdensome. So respite care, although very helpful, may not be sufficient to really fully ameliorate that burden and maintain a healthy level of well-being. So in the short term, caregivers may fully be capable of taking on this role, managing and coping with the stresses of caring, but it can be over the long term that can really prolong this burden and stress and unfortunately lead to burnout. As mentioned in the previous slide, this can decrease quality of life in both parties here, and then can unfortunately result in a reduced quality of care. Simultaneously, let's not forget that the survivors are coming into a new setting and adapting to their own set of newfound adaptive problems and functioning capacities. And they may be experiencing more downtime. They may have more limited social and employment opportunities. And they may begin to manifest symptoms of loneliness, frustration, helplessness, which of course, an increase in the survivor's distress can also impact a caregiver's level of burden. So this combination of high caregiver burden, increased isolation and loneliness for both survivors and caregivers, potentially reduced access, can really create this sort of feedback loop where distress from one party is impacting the other, leading to a continuous cycle here. So as providers, these are, I hope that by talking about all of this, it doesn't seem to be an overly complex process, but what I hope is that we can all see how many areas there are to intervene in this case. So while caregiving may be burdensome, there are plenty of areas within this relationship that we can provide supports to, provide education about, and really hopefully help decrease the burden and distress among all parties. So caregiver capacity, as defined by Everhart and colleagues in their paper just very recently, was defined as the extent to which caregivers possess the knowledge and the skills required to care for the injured. So this is not an all or nothing equation here. For example, a caregiver can possess knowledge, but not necessarily have developed the skills just yet. And they may possess the skills, but not have the knowledge to really act on. And McIntyre and colleagues found that families' capacity to assume the caretaker role was influenced by variables both intrinsic to the caregiver and to the survivor, as well as a more extrinsic kind of factors of available support, other family dynamics. So things that are intrinsic to the caregivers are their own attitudes and beliefs about the injury. Maybe in this case, there's potentially feelings of duty, guilt, frustrations, whatever it may be, their own coping skills. So how do they deal with those emotions that are coming up throughout this recovery process? Then we have characteristics that are intrinsic to survivors. So the survivors' attitudes and beliefs about their injury. They're going through oftentimes a new defining process of developing a new sense of self, coping with injury, coping with new emotions that are coming up for them. Other things that are intrinsic are, for example, the functional status of the survivors. So how well can they conduct their activities of daily living? How independent are they? How well can they self-manage their own emotions that are coming up? And of course, then there's the relationship with the caregiver. So brain injuries don't occur in a vacuum. Before that injury, there was a relationship most likely there was a relationship between the caregiver and the injured party here. And that relationship's really important. For example, if it's a parent-child relationship, it could have been extremely close, it could have been very supportive, and this transition may occur somewhat smoothly. On the other hand, it may have been a sort of acrimonious relationship. Maybe it was, the two did not get along well, they weren't close, and this new role taking for both individuals can really be more difficult to overcome. Then there's family dynamics. So looking at the broader circle around just the caregiver and the survivor, and thinking about family systems, there can be the life stage of the family. So is a caregiver actively employed? Are they moving towards retirement? Is the living situation stable? Are they going to be moving? And then other available supports around the family. For example, is there a big extended family network around them? Are there grandparents, cousins to provide extra help when needed, to provide support, to engage the survivor in social interaction? And then none of this is a static sort of occurrence here. These things are dynamic, they change over time. Recovery can both progress and regress. It can slow and speed up. Family circumstances themselves can change. For example, divorce, children being born, new jobs, etc. And then changes in support, people coming in and out of this system, at different times across this sort of continuum. And I hope it's becoming clear at this point that any breakdown in this relationship between the caregiver, the survivor, but also other factors, outside of them, can really negatively influence this recovery process. And I think just one example that's really helpful to sort of more concretely think about. For example, Everhart mentioned a handful of studies that found that the caregiver depression is bidirectionally related to the survivor's physical health and disability status. So as health and disability increases, as does caregiver depression, but it being a correlational relationship, it could also be that caregiver depression is related to poorer care for that survivor, which could then increase, physical health problems and disability status. So to focus a little bit more on the caregiver, addressing caregiver needs over time is really imperative to the long-term well-being of the caregiver and the recovery of the survivor. And the dynamics of this relationship really have to be assessed early, but also regularly, so continuously throughout the process. Over time, the caregiving experience itself may become more predictable, less stressful as caregivers adapt to their new roles. However, that unfortunately, as Fraser and colleagues discovered, that this can lead to an underreporting of concerns. So as things become more routine, more predictable, concerns may not be at the forefront and may go unrecognized. So Vangel and colleagues found that survivors' life satisfaction was also associated strongly with the caregiver's level of perceived social support. And the strongest predictor of survivor emotional distress was caregiver life satisfaction. So here we again see, this sort of give and take dynamic relationship between the two. And I think notably as a someone interested in neuropsychology myself, that a higher self-reported caregiver burden is associated with poor survivor neuropsychological functioning. And that I think is just an interesting sort of look at how these sort of basic cognitive functions can really generalize to a functional impact on a relationship between the caregiver and the survivor. So how do we address these dynamics and these barriers? Well, first, I think as with anything, the first step is to recognize that dynamic, to flush it out, to acknowledge it, and then as this rehabilitation process continues, to consider the importance of the caregiver throughout the process. So needing to pull in that caregiver into the decision-making process as to the extent possible. So in decision-making processes, including really all parties, the survivor, if possible, the caregiver, if possible. And then formal counseling and psychotherapy can also be considered in this context. This can really foster caregiver understanding of their own emotional experience, their attitudes towards caregiving, and I think very importantly, can facilitate communication between the caregiver and the survivor, which really could be essential in sort of hopefully preventing a lot of the potential problems of that bidirectional relationship if one of those factors is influenced, for example, depressive factors. So increasing communication can really foster a sense of trust and hopefully a growth mindset, so towards the rehabilitation process. And critical elements within this context really include addressing the evolution and the phase of the needs. So as I mentioned before, this is a dynamic process. Things change over time. Providing emotional and psychological support throughout this as providers, intervening at all moments, even if the stress isn't particularly high, if it's not a crisis situation, but providing that support as a sort of preventative measure. Similarly, providing anticipatory guidance. So the more we as providers learn about the caregivers, the survivors, the more we understand about that relationship between the two, the more we can anticipate and hopefully guide that process to prevent any negative outcomes. Problem-solving skills can be really important here, as can stress management strategies and behavioral management strategies. So going back to Everhart's statement about the caregiving capacity, knowledge and skills was both included in that point there. And I think this third bullet here points out that this is an intervenable moment to provide that knowledge and to develop those skills. And with any skill, it requires practice over time. Facilitating life planning is extremely important. So given that the recovery and rehabilitation process is continual, it can be long-term, having a plan in place of what to do when this happens or when an individual reaches this stage of life can hopefully prevent any surprises coming up and really make the whole process much smoother. And throughout it, emphasizing as to the extent possible of getting back into the community to reintegrate back as much as possible into a new functional status within the community. So building that in within any sort of treatment protocols and rehabilitation processes. So as that last bullet states, reintegration back into the community is really a vital component of rehabilitation. So I'm going to hand it over to Usha now to elaborate on the socialization aspect of this.
Sounds good. Thank you, Kevin, for that overview and some really great background information. So now we'll shift gears a bit to discussing some more aspects of community reintegration, starting with an emphasis on socialization. So as we know, community reintegration is one of the primary goals of rehabilitation, with the idea being to translate and generalize skills that are learned in the treatment setting to everyday life at home and in the community. And to that end, it's been defined in the literature as being part of the mainstream of family and community life, discharging normal roles and responsibilities, and being an active and contributing member of one's social groups and of the society as a whole. And it's important that reintegration be comprehensive and also very individualized. In addition to goals like return to work, return to school, and so on, reintegration can also include non-work related roles, such as engaging more in social relationships and leisure activities, especially for older individuals potentially. And it's also important to consider environmental variables in order to identify any potential barriers to community reintegration. This could include financial characteristics, for example, poverty levels, access to residential services, access to completing disability applications, and brain injury funding, safety in the community as well, such as violence, drug use, and even accessibility to adequate housing and home owning. And in a study by Sander and colleagues, they actually found that when controlling for demographic variables, pre-injury characteristics, and injury variables, neighborhood characteristics actually accounted for a significant portion of the variance in Glasgow outcome scale, so which categorizes the outcomes of patients after TBI, and also satisfaction with life scale. So we can certainly see how neighborhood and general community factors can impact recovery and brain injury outcome. So why is socialization important? So individuals who've had brain injuries commonly report feelings of isolation and abandonment, given that a lot has changed: their self-perception, their sense of identity, their functional status. So a lot of changes in their overall sense of self and functional abilities. And so survivors may experience a loss of identity, purpose, certainly loss of independence to some degree, and difficulty relating to others given their challenges. So in turn, those experiences can magnify difficulties within social relationships with family and friends, and that can then increase feelings of loneliness and perhaps resentment. So with an emphasis on activities to promote social integration, it can help to foster a sense of belonging, independence, adjustment to disability, all factors that have been shown to be related to higher survivor life satisfaction. And so overall, the goal is to really foster a sense of agency and purpose as a contributor to the home or community, and overall just to increase independence and life satisfaction. So at this point, we've discussed the transition from the acute setting and some of the issues that come up for both the survivor and the caregiver. And now we'll get more into the community reintegration program characteristics, first for survivors, and then we'll get into caregivers. So one of the goals of comprehensive rehabilitation programs is to improve psychosocial functioning. And the important thing here is for this to begin early and to be included in a structured treatment plan. So specialized social skills training, for example, can help survivors develop a positive social identity and provide the opportunity to practice social skills. We know that impulsivity, for example, is a common consequence, can be a common consequence following TBI, and certainly can impact interpersonal and social relationships and navigating certain social situations. Brain injuries can also sometimes be hidden disabilities, as we know, where you have the cognitive and behavioral consequences of brain injury, but somebody's physical appearance may not be compromised. And so this is something the general public may struggle to understand, even though brain injury awareness has increased over time. So in a study by Hashimoto and colleagues, they actually found that a long-term hospital stay may not adequately prepare survivors for community reintegration, and the transition from inpatient providers to outpatient providers can often lack the coordination across provider that's really needed to foster integration. And the idea of coordination across different providers can be essential, considering providing adequate treatment. So community reintegration programs ideally should be appropriate for survivors and also offer a multidisciplinary team treatment approach to the development, coordination, implementation, and management of treatment overall. And unfortunately, some settings may lack specialized staff and individualized treatment for individuals with acquired brain injury. Aged care facilities may not meet, for example, may not meet survivors' needs, and coordination of care might be lacking. And this could certainly occur for many different reasons, perhaps simply being limited in terms of resources and or access to having specialized clinical training. And so when we refer to comprehensive community reintegration programming, ideally it should include clinical staff who are specially trained to treat individuals with acquired brain injuries and their caregivers as well. And as Kevin mentioned earlier, we know that brain injury affects everyone differently. So this approach certainly helps to provide an individualized approach to treatment, assessment, and monitoring of survivors and their progress throughout rehabilitation. And it also allows therapists to really capitalize on the strengths of survivors and foster pro-social behaviors, and also remediate any maladaptive behaviors in order to maximize gains over time, particularly in the elder years, where you may have the effects of natural aging superimposed on brain injuries. So you may be working to prevent further decline. And so now we just wanted to highlight some of the issues that have come up in the literature regarding programming across various settings. So despite documented benefits of community reintegration residential programming for individuals with ABI, there's quite a bit of variability across these settings, which makes it a bit difficult to quantify the relative effectiveness of these types of programs. So for example, Glenn and colleagues interviewed 13 home-based community integration programs, and they found variability across different variables. So client population, for example, the number of clients, the amount of time spent in team meetings, varying length of stays, and even variability in the time from injury to admission. With home-based programs, these can also be difficult to assess and also vary across different factors as well. And Trudell and colleagues actually highlighted a few different models of programming. For example, they looked at neurobehavioral focused programs, which included 24-hour supervision and behavioral management. They looked at residential community programs, which included also 24-hour supervision or support. There was treatment in the residential setting, there was access to a full comprehensive treatment team, and also opportunities for community reintegration activities. Additionally, they looked at comprehensive holistic programs, which had more intensive services. There was a focus on improving awareness after brain injury. They included a day treatment program and really a multimodal rehabilitation program. And finally, they also looked at home-based programs, which emphasize, an individual's ability to live at home and self-direct their own care. These programs provided education, telehealth services when appropriate and when needed, and also supplemental services. And it's been found that more intensive-based programs, so specifically programs where you have licensed staff treated or trained in ABI, are more effective than supported living settings. And this is actually supported by earlier findings from Cicerone and colleagues, showing that intensive community-based treatment programs offering an intensive integrated approach that highlight psychosocial intervention actually were more effective than those that did not. And so specifically, this involved programs with an intensive focus on cognitive rehabilitation. So this could be in the context of having highly structured group and individual treatment, a focus on communication and interpersonal skills, focus on ADLs, and also assessments to evaluate readiness for education and vocational activities. So these are some important factors in terms of community reintegration programming for survivors. And now we'll shift a little bit to talking about caregivers. So again, as Kevin mentioned earlier, assuming the role of a caregiver can potentially be overwhelming initially, given that this can be a role that is lifelong. Caregivers may experience emotional and social isolation, as well as concerns about their own needs as a result of their caregiving responsibilities. And so appropriate emotional support for caregivers is really essential, and this ideally should be ongoing and comprehensive throughout the entire rehabilitation continuum. And this is certainly important for continuity of care and to provide support for the loved ones, particularly after the initial post-injury period. As Kevin mentioned earlier, the role of the family and other supports is quite important, particularly in facilitating that transition out of acute care, but we also want it to be comprehensive and also consider the caregiver well-being throughout the course of their loved one's rehabilitation. And now we certainly recognize that not every program may be able to offer caregiver-specific support for various reasons, such as lack of access to resources, funding challenges, or simply staff availability to address those needs. But it has been recommended that a multidisciplinary team that provides services for both family and caregivers can help to ensure the formation of adequate psychosocial support. And this can include services that provide psychoeducation, for example, but also programs should strive to incorporate counseling, for example, by professional staff to address the family system as a whole. Since we know, again, coming back to brain injuries and medical illness in general, having a ripple effect impacting not only the patient, but the entire family unit. And so overall, there's evidence emphasizing the need to involve and provide support for the caregiver across the course of rehabilitation. And so to that end, family counseling that enhances communication and facilitates problem solving is certainly beneficial. It's not uncommon that the patient and family may have to navigate certain various issues, for example, working with physical therapy and occupational therapy to ensure safety in the community and and at home, proper use of assistive devices within the home, coordinating home-based therapy and nursing services and so on. And in fact, the literature encourages clinicians to seek out caregivers and assess their level of distress and mitigate their symptoms, and also offer counseling within that same framework. And now, although our literature search did not directly assess or address cultural and diversity factors, we do want to highlight the importance of these factors within the family unit and structure. So depending on cultural background of the patient and the family, this may color the way that they view caregiving and disability as well. Certainly in some cultures, some families may be more involved than others, and also given cultural role expectations, perhaps caregiving may fall to the children and so on. So it's definitely something to be mindful and respectful of within the context of assessment and treatment. And again, going back to the idea of continuity of care, Gan and colleagues did acknowledge the importance of programs assisting and directing the rehabilitation process to ensure coordinated continuity of care. So case management and long-term planning are critical elements of this. And it's been recommended that ABI caregiver support services be included as having continuous lifelong access to services that really responds to changing needs over time, specifically having psychosocial and instrumental support, as well as counseling by professionals trained in ABI. These things can really enhance survivor and caregiver quality of life. And it's also been noted that although caregiver distress remains generally high over the long term, it may increase over time for some and decrease for others. So there's some fluctuations there. So caregivers with poor support may become increasingly distressed over time rather than adjusting to distress. And caregivers with more adequate support may not be as greatly distressed despite that long-term caregiving. And so identifying the characteristics of the caregiver, survivor, and caregiver-survivor dynamic, including family, as they change over time is really important in terms of realizing the most effective intervention for both the caregivers and survivors over the course of rehabilitation. And so according to an NIH consensus statement, programs should be interdisciplinary, comprehensive, individualized, and it should include various elements. And so these include cognitive and behavioral assessment and intervention, caregiver and survivor input in the planning and coordination of individualized programs, community-based services that emphasize socialization, and also direct caregiver and family intervention and substance use evaluations when appropriate. In another study by Frost and colleagues, they found that there were certain shortcomings in how effective community-based programs were, and this included failure to meet the needs of the family as a whole, so not maybe addressing caregiver-specific needs, and providing community education. So for example, addressing the lack of public knowledge surrounding acquired brain injury. However, community-based programs did meet patients' emotional, social, and cognitive needs, as well as overall positive quality of life. So at this point, we've highlighted important programming variables for both the survivor and caregiver, and discussed how important it is for support to be provided early on and to be individualized, and also involve the family as a whole when possible. And so based on all the literature, there are all the literature that we reviewed, there are some important elements from the programmatic perspective, starting with outpatient day treatment programs. And so in this setting, as well as others, it's important for treatment, again, to be individualized based on the patient's needs. So also, their level of independence based on, their needs and functional skill set should certainly be considered. Scheduling of the patient's program should consider other demands that the patient may have, such as their involvement in work, perhaps they're still working part-time or things like that, volunteer activities, recreational activities. And treatment protocols should typically be multidisciplinary and implemented within a cohesive team setting, with treatment led and supervised by neuropsychologists and other licensed therapists. So speech language pathologists, occupational therapists, physical therapists, really the entire treatment team. And this can include individuals who are also certified in cognitive and functional life skills training and vocational therapists. So individuals certified by the Academy of Certified Brain Injury Specialists, and also consulting physiatrists as part of the, from the medical perspective. Having multilingual therapists and supporting staff can also be important in both care and providing, facilitating communication with families. And also having regular support meetings and psychotherapeutic intervention that incorporates the family as needed, certainly important for continuity of care, and also providing that support to the family, and also addressing any potential barriers to care. So those can be addressed. Additionally, clinical rounds, didactics for ongoing training, case conferences with families should occur regularly. And this is important for the staff to keep up, their knowledge updated, their training updated, and also just to provide the, the best care possible. And also case conferences, including the family, can be especially important for keeping the family involved, as I mentioned, and updated with their loved one's progress, and continuing to identify any challenges with reaching their treatment goals. And in terms of case conferences and continuity of care in general, the role of case management is really quite essential. So each patient is assigned a case manager who's responsible for continuous monitoring of treatment and progress overall. And not only do case managers provide survivors with a voice within their place of care, within their place of treatment, but also they're the front line to really include the family in the formulation of treatment goals and creation of an individualized and collaborative approach. And they also manage a really extensive feedback system between the survivor, the family, and other support persons within, within the therapy team. And so they really help to maintain relationships with community resources as well. This can be helpful with identifying opportunities for social and recreational engagement, as well as identifying any potential opportunities for employment and volunteer activities as well. Okay. So what are the benefits of having this coordinated multidisciplinary team approach? It can facilitate the monitoring of medication side effects, for example. The entire team is involved, not only physiatry from the medical perspective, but also various therapists who can observe the patient in different treatment settings and really be attuned to any changes they may notice in a patient's cognition, behavior, their emotional functioning. And to that end, the team can rapidly assess any changes in medical, psychiatric, or functional presentation. And they can also identify any psychosocial stressors, such as strained family relationships, and help to navigate this in a really collaborative way with the patient. Additionally, comorbid disorders such as anxiety, depression, substance use disorders, and other neurologic disorders such as seizures, which we know can be common following brain injury, can be present. So it's important to notice these symptoms and for them to be addressed within the context of treatment. And general community supports may not always recognize or adequately address these aspects. So certainly something to know in terms of comprehensive community reintegration programming. And so the main idea is, here is in providing comprehensive care is to provide an individualized approach to the assessment, treatment, and monitoring of individuals with comorbid ABI and other disorders as well, by including the entire treatment team. And we have this chart here just to highlight what we mean by a multidisciplinary treatment team, with the key players being neuropsychologists, speech language pathologists, occupational therapists, physical therapists, cognitive and functional life skills therapists, also therapists specializing in substance use disorders, again, because it's well documented in the literature that substance use disorders and TBI can co-occur. Alcohol use, for example, can be is a well-cited cause or consequence of brain injury. And also as part of the team, we have vocational therapists, residential counselors, case managers, and consulting medical professionals from different areas. So physiatry, neurology, psychiatry, can certainly be others as appropriate, like orthopedics and stuff like that. So another element we'd like to highlight in terms of program characteristics is residential programming. So residential programs are comprised of community dwelling homes with 24/7 supervision by clinically trained staff with transportation usually provided to and from day treatment programming. They're typically located close to community resources like shopping centers, post offices, not only for convenience, but also to allow individuals to practice and reinforce strategies that are learned within treatment. And so this is something that case managers and treatment staff typically might assist with, for example, having community outings to the grocery store. So this entails having adequate supervision by the staff to practice, safety navigating the streets and parking lots, navigating the store itself, money management for purchasing items, and so on. And so community reintegration, comprehensive residential programming can strengthen the generalization of those learned skills and behaviors from the treatment setting to daily life and within the community. And in turn, this could lead to a greater sense of autonomy for the survivor and improvement in their self-esteem, as well as a sense of integration that might be lacking within the home. And so it's been shown that an earlier transition to the residential setting may actually help to alleviate caregiver distress, burden, and burnout. So families who are caring for a loved one with a brain injury may find themselves ill-prepared and ill-equipped to manage certain challenges, as Kevin described earlier. So the residential setting, with more supervision and assistance can certainly serve as a sort of a bridge back to more home-based care with the family. Also, earlier placement may foster the acquisition and management of functional gains from treatment and minimize potential negative effects of any vulnerabilities, for example, emotional difficulties, since those can be addressed within the context of psychotherapeutic intervention. And finally, ongoing communication is certainly present between the outpatient staff, residential staff, and the caregiver and family as well. So there's constant monitoring of the patient's progress toward their goals. So the table here just highlights the key elements of comprehensive community reintegration programming that have been identified in the literature, many of which we've just gone over. So having cognitive, emotional, physical, and functional skills intervention by licensed therapists and brain injury certified staff, an individualized approach to intervention, and the knowledge of the specific population, So this can include the specific assessment of brain injury related variables and monitoring of substance use when it's relevant. Case management, having the involvement of case management to emphasize coordination of care, continuity of communication, and just ongoing needs assessment and long-term planning, potential placement in a residential setting, for example. This includes primary emphasis on socialization, as we discussed, with a multidisciplinary community-based intervention. And also an emphasis on caregiver and family, and also the caregiver-survivor relationship. And finally, ongoing clinical intervention for both the survivor and also the caregiver and family, and regular involvement with their treatment. Again, just to continue monitoring goals and progress toward treatment and identifying any barriers to accomplishing them. So overall, taking the literature into account, there is a need for empirically studying the efficacy of new and current interventions within comprehensive rehabilitation programming. A great deal of literature is qualitative in nature, and many are limited in terms of sample size, small sample sizes, and just a lot of variability across types of programming, as we pointed out. However, we do see consistency in a few different areas. So based on our narrative review of the literature, we see that there is a need for long-term community integration programming with the ABI population, as well as the importance of having the larger rehabilitation structure be intensive with appropriately licensed and credentialed staff. And we see the importance of including caregivers and the family, certainly early on and continuously in all aspects of the survivor's care, and also attending to individual needs within the context of family and the support system, as well as cultural factors as well. Also, having continuous communication across staff and caregivers is important for continuity of care and continued monitoring of their progress. Again, identifying any ongoing challenges. This can certainly be helpful in terms of long-term planning and ongoing just monitoring of progress over time throughout rehab. So taken together, the larger rehabilitation structure must be intensive, individualized, well-coordinated, with continuous communication and assessment of needs. It must also emphasize socialization and caregivers and families, as well as a primary element of program intervention throughout rehabilitation. And so we hope that our presentation today has met our goals that we laid out in the beginning, and really highlights the essentials of care for a survivor of brain injury, caregivers, families, and the essentials of programming as well. So thank you all for your attention and participation in the chat. We're happy to answer any questions at this point.
Thank you so much, Usha and Kevin. We have a few questions. So the first one comes from Kate O'Connor. It's actually a two-part question. So part one, do you know what percentage of caregivers suffer from clinical depression once a loved one passes away?
Good question.
That is a good question. And so we don't actually have a percentage. We didn't come across any of the studies, at least, that were included in the present paper that really touched on caregiving once a loved one has passed away. However, I think that is a very fruitful avenue for future research and very interesting. I do know, for example, I cited earlier on the Smeets article, caregivers do experience about 1/3, so about 30-ish, 3%, at least in that study, of clinically significant depressive symptoms. And I think to tie it back a little bit to the current review here, I think grief is an important component that you bring up here that I think is really important to consider. The grieving process is a natural process, even in the absence of the loss of life. So caregivers themselves are going to be grieving the loss of potentially the individual they knew before the injury. And the survivor themselves may also be grieving the loss of a lot of aspects of their life that they just can't have the same way anymore. So I think grief is a really vital component throughout the process, but I'm sorry that I don't have those percentages for you.
Part two of her question was, do you see a lot of caregivers suffering from anxiety disorders they didn't have prior to either caring for someone or from them passing away?
Yeah, that's a great question. Yeah, I'm not, as Kevin said, I'm not sure about like quantitatively specifically, but I think it's, you bring up a good point in terms of that pre and post. I think, again, with a lot of the studies that we came across were very, qualitative in nature, sort of anecdotal almost. So I think it's a great future direction for research. We know qualitatively just that, if not properly managed and supported, caregivers can certainly have increases in emotional challenges, in terms of providing care with anxiety and depression. But specifically in terms of numbers, I'm not sure, but I think it certainly highlights the importance of a really nice area for future research. Kevin, did you have anything to add or come across anything
Not within particular studies, but I do think it brings up another really good conceptual point here of the vulnerabilities that come into play post-injury. So as mentioned earlier, these things don't occur just suddenly out of in a vacuum. People come in with a whole host of strengths and weaknesses potentially pre-injury that can really impede or really help the recovery process. Anxiety is certainly one of those. That could be, sort of a generalized anxiety. It could also be stemming over into sort of post-traumatic anxiety, which certainly is common following an injury like that.
Thank you both. Our next question comes from Heather. In your research, did you notice any differences in comments from survivors in regards to levels of happiness between hired caregivers and family caregivers?
The short answer is no. So we did not come across any of those statistics. Most, I would say, the very large majority of when we were talking about caregivers are referring to family members, most often parents, but very frequently as well spouses. Hired caregivers in these cases were more along the lines of what was included within sort of a comprehensive multidisciplinary team. There's certainly, other factors that pop up throughout the literature, such as home-based interventions and services that can assist with caregiving. There's respite care that has come up a few times, but our focus was really on more of a familial kind of caregiving survivor relationship. So again, I feel like I'm repeating myself, but sorry, I don't have the statistics for you.
Okay, our next question comes from Caitlin. Are there any current community programs that allow ABI, either adult or pediatric survivors, to meet other survivors outside of the outpatient day programs? It seems to be a follow-up to that. Who should families be connecting with after their discharge from outpatient day programs? Are there any community-based social workers they can connect with?
There's certainly resource communities, and I think going back to very early on in the presentation, the resources are out there. There's not enough of them, but they are out there. Part of the problem, though, is that transition, that smooth handoff that can unfortunately be fumbled, be coming from the hospital and acute care following that recovery. As more and more survivors survive and the hospital stays can be, individuals can be stabilized shorter, that it takes a lot of really, a lot of running around and trying to find those resources. There's certainly support groups out there for individuals to, meet up. There's certainly, informal sort of online communities for survivors. With, I think, a good multidisciplinary team in place, or at least the coordination of services across care, those resources become much easier to access. Obviously, caregivers are burdened already just with the day-to-day activities of caring. So having professionals that are trained and in network with those resources are really going to be the ways to find them, I think.
Thank you both.
Yeah.
Are there any other questions from our audience? Give everyone a couple minutes. I know sometimes it takes a minute to type things in. I see Kristen also provided some information in the chat on support groups through the Brain Injury Alliance.
Awesome, thank you.
Just a reminder, Kristen also entered into the chat the link to complete your evaluation. So make sure that you are completing the evaluation for this workshop, as well as the final evaluation for the entire seminar today. So please be sure to fill both of those out. I'm also including the link here for the Zoom room for our closing remarks, which begin at 3:10. Okay, we have one more question that came in from Shannon. Is there a push for at-home caregivers to be paid through insurance in non-Medicaid situations?
Unfortunately, since I'm still pretty new in the field, I don't know enough about the insurance process to really be able to answer that confidently. So I'm not sure. Usha, I don't know if you have any more experience or knowledge about that.
Yeah, I think I'm in the same boat as Kevin, unfortunately. Still sort of, I think being on internship now, this is kind of like my first experience getting a lot of exposure and seeing, you know, how insurance works, but I'm not specifically sure about that, you know, caregiving, that aspect of caregiving in terms of the insurance. So I'm sorry, I can't answer that as well.
Another question came in from Casey. What suggestions could you give community rehab professionals in helping clients meet social and community-based goals in expanding their social networks and connections to community activities?
So I think, you know, given that the focus of the literature review here was really on getting back into the community, I think it really depends on each of the professionals and their own field of work. For example, physical therapy may be much more focused on safely navigating the community to really assist in being able to get back out there, to go on, like Jenna, for example, I know that you have in the past taken people on community outings to really practice those skills, which can really foster a sense of, you know, getting over a lot of the anxiety of being back in a community, and can also, you know, just give the chance to meet more people. Occupational therapy may have their own perspective, and psychological treatment certainly will, you know, attempt to find first achievable goals. You know, what do you feel capable of doing? Who do you feel, you know, old friends maybe that you can reconnect with, new networks that are coming up as you go through the process of people you meet just in therapies or going to wherever it may be of the support groups. So I think it really depends on the discipline, and case management can certainly have that sort of broader perspective of the resources, what's accessible within the area. So again, getting back to that multidisciplinary approach, each professional is going to have their own perspective and their own tips to sort of navigate that process.
Yeah, in addition to what Kevin mentioned, you know, I'm thinking about my setting as well, where you know, being at Rusk, there are a lot of different programs specifically for individuals with, you know, with brain injury. So I'm currently involved in an awareness group where, you know, we're currently doing it via telehealth, but it's a way to you know, provide psychoeducation about you know, either awareness or lack of awareness surrounding brain injury and the impact on the patient and their family. Oh, I see the warning. And their family lives. But also the thing about the groups is that it really fosters a really nice strong sense of support between the members in the group. They're able to relate to each other and really foster that sense of, you know, like as you were asking about the social, you know, kind of integration and relating to others. I think it's just a really nice aspect of those sort of those groups, and also other types of cognitive groups that that individuals may have access to. Again, going back to the insurance, depending on what it covers and things like that. But they are also really great resources.
So I had the pleasure of working with both Kevin and Usha in an outpatient day program. And as Kevin was saying, I did as a PT run some community integration programs. And based on what they were just saying, I would also just add to that to work collaboratively with the interprofessional team. I think I can't tell you how many times I went to both Usha and or Kevin to kind of collaborate on something to help promote community reintegration for certain clients that we were working with. So I think just as Kevin said, everybody has their own perspective, and trying to benefit from the fact that we have so many different people to use as resources, I think is really helpful.
Definitely.
Sorry that I'm answering your questions, guys.
No, we appreciate the additional perspective. Yeah,
yeah,
it's multidisciplinary here.
Interdisciplinary, right?
Right,
That's what
exactly.
it's all about. Okay, any other questions? I'll give everyone another minute or so to type things in.
These are great questions. Thank you, everyone.
All right, well, if those are all our questions, it seems. Thank you both. That was a very informative, wonderful presentation. We're very appreciative of your time that you shared with us today. Thank you to all of our attendees. Please, like I said, please fill out your evaluation forms, and the link for our closing remarks, which starts at 3:10, is included in the chat as well.
Thank you, everyone.
Thank you so much.